On behalf of Lung Foundation Australia, I'd like to welcome you to this webinar on your COPD checklist, 10 steps to better care. My name is Rebecca Corbett. I'm one of the respiratory care nurses here working on the phones at Lung Foundation Australia, and I will be your host for today's webinar. In honour of World COPD Day today, we are presenting this webinar around 10 steps to better COPD care. And we have a stellar lineup of speakers for today who I will introduce to you shortly. So before we get started, I'll hand over to our speakers to introduce themselves so everyone joining us today can put a face to each name. So I'll hand over to you first, Natasha. So Associate Professor Natasha Smallwood, and then we can follow the order on the slides after you. So over to you, Natasha.
Thanks very much, Beck. So my name is Natasha Smallwood. I'm a consultant respiratory physician at the Alfred Hospital, where I lead a very severe lung disease service, and I particularly specialise in seeing people with COPD and people with severe breathlessness. In addition to my clinical role at the Alfred, I'm the head of the Chronic Respiratory Disease Research Group at Monash University, and we do a lot of work in trying to discover new treatments for breathlessness and looking at new ways to support people who have very severe lung disease, and in particularly looking after people with COPD. Thanks, Beck.
Thank you so much, Natasha. And I'll move over now to Naomi. If you'd like to introduce yourself, Naomi.
Hi, my name's Naomi. I'm a working mother of 3. I have COPD and I've been part of the Lung Foundation for the last couple of years.
Thank you so much, Naomi. And Ken, I'll hand over to you as well if you'd like to give an introduction.
Yeah, Ken. So I was diagnosed in 2002, so I was diagnosed a long time ago. I was hospitalised with pneumonia and I nearly died, and they then found that I had COPD and I've had it since. I still get around a fair bit. I'm in Melbourne at the moment. I'm in Gippsland in Victoria. I wander around a bit with my beautiful dog. It's a beautiful day down here in Yarra, which is in Gippsland, and the sun's shining, and we've just been to a lovely cafe for lunch. And so even though I today, because of the weather, I'm fairly wheezy, and this is what happens. But as my daughter tells me, as long as I try not to do too much, and it says there, a slower pace. I have trouble doing that, but I'm still doing it. I've learned to cope with my COPD. I turned 2 by 40 a couple of months ago. I refused to use the word 8. So I managed to hang in there for a long time. I've done lots of trips and things, and I cope reasonably well most of the time with my COPD through a specialist and my GP.
Oh, thank you so much for your introduction, Ken, and glad that you've got some good weather down there. It's raining and pretty grey here in Brisbane, where we're broadcasting from. So, all righty. So thank you all for your introductions. Really looking forward to today and hearing all of your insights and experiences. So let's now to kick off today's webinar. We will start with a presentation from Natasha on the newly launched My COPD checklist. So Natasha will take us through this checklist and why each step is essential for improving your care and how you can implement them in partnership with your healthcare team as well. So afterwards, we will have a pre-submitted question portion, so questions that have come forward through to us. We will address those, and we'll also end on a live Q&A session as well. So please feel free to submit any questions that come to mind throughout the presentations for the panelists to answer again in that Q&A section. So I'll hand over to you now, Natasha, to your screen and to your presentation. Thank you.
Well, so I'm delighted to talk about COPD, given it's one of my favourite things. And as I said, I look after a lot of people with COPD, so it's where I particularly subspecialise. So I'm really happy to be able to talk to all of you about what COPD is and really actually about how you can optimise your care and really be a partner in your healthcare. So today what I'm going to talk a little bit about is what COPD is, what good care is like. So I'm going to talk about the new clinical care standard that has recently been released. And then I'm going to talk about the My COPD checklist, which the Lung Foundation has also just released. So in terms of COPD, so it's funny because when people come and see me, they often don't really understand what the condition is. So many people will think that they've got asthma or don't really understand what COPD is. And you're not alone if that's you, because the majority of people actually in this country don't understand what COPD is. And that contributes to why we don't actually get enough funding to do research for this condition. So COPD is an inflammatory condition. It's a chronic condition, which means it lasts for a long period of time. And unfortunately, there is no treatment. So we do have, there's no cure. We do have treatments, but we don't have anything that can reverse the damage or cure it. With COPD, it leads to, with inflammation, we typically find that it causes airflow limitations. So you get inflammation in the airway, which can cause some narrowing of the airway. There can be mucus buildup or sputum. And it's that narrowing and sputum that causes the typical symptoms of breathlessness, cough, and wheezing. And obviously Ken was just telling us about his wheezing today. So those are really typical symptoms which are related to the airway focused problem in COPD. Some people also have emphysema, and emphysema is where you get destruction of the little air sacs where gas exchange is occurring. So they're the sort of critical interface of the lung. And some years ago, you may remember that we had a smoking cessation program, a television advert campaign where there were cigarettes burning holes in bubble wrap. And that's a really good way to think of emphysema, as that damage to the lung and that peripheral lung. So not everybody has emphysema. So some people with COPD have both the airway problem and the bronchitis, but some people just have the airway problem. So everyone's a bit different with this. And it really, it's important to understand that, because it's why we use certain tests for diagnosing COPD. COPD is really common. So when we look generally in the population, you can see 1 in 13 people has it. But actually, if you look at people who are a wee bit older, it becomes much more common. So COPD is not an uncommon disease. It's actually a very common illness. And for many people, COPD is caused by smoking. So for about 70% of people, there is a smoking history. And really, we're talking about someone's got to have smoked 20 cigarettes a day for at least 10 years, often actually more than that, to develop COPD. But in 1/3 of people, there is no smoking history, and yet this person has COPD. So we know that about 30% of people, it's related to something else. And in fact, we now recognize that there are numerous different causes for COPD. So for example, prematurity, when a baby is born early, or when someone has severe infection in childhood, particularly pneumonia or tuberculosis, you can end up with damage that leads on to COPD. We know that exposure to certain pollution can cause it. So particularly when people burn biomass fuel and use that for heating and cooking inside, which doesn't really happen in Australia, but happens in other countries, that smoke exposure that they get can cause COPD. So we now recognize actually that there are a variety of risk factors that cause COPD, and that they can occur throughout the lifespan. So it's not just a smoking related disease. So as I mentioned briefly just now, we do now have what's called a respiratory clinical care standard. So that was developed by the Australian Commission for Safety and Quality in Healthcare. And this is the first ever standard that we have had in respiratory medicine. So there are only actually about 17 clinical care standards that have been written in Australia. And of those, this is the first one that we've got in respiratory medicine. So it's really exciting. And myself and a colleague of mine were the only 2 respiratory physicians in the country who got to contribute to the writing of that standard. It takes a very long time to write a standard. But what we're aiming to do is actually highlight what everybody should expect if they have COPD, and what they should expect in terms of their care, both when they're seeing their GP, but also when they're seeing their specialist. So the standard actually covers 10 different aspects of care and highlights what we should do, but what you should expect that we should do as well. So clinical care standards are written for health professionals, but they're also written for people who may have this illness or who might be looking after a loved one with this illness. So that means that there are sections which are written in simple language so that anybody can understand it. So if you are interested, if you just Google the Australian Commission on safety and quality and look at the COPD clinical care standards, you will find that you can read it and find things that are useful for yourself in terms of your own care in the future. The other thing I'd like to really stress is when we developed that standard, and it takes about 2 years to write a standard like this with a lot of people involved, we had a really strong focus on being equitable with care and on making sure that there was cultural safety, particularly for people from First Nations background. So it's a really impressive piece of work. So in addition to now having a new clinical care standard, the Lung Foundation has just launched this COPD checklist, which actually marries up very nicely with what we wrote in the clinical care standard. And it's all about trying to help people to optimize their own care. So we know that empowering people to better self-manage is critical because that enables you to know what you should do, when to ask for help, and how to stay as well as possible for as long as possible. So that's what this checklist is about. And again, the checklist, like the standard, has 10 very simple points to go through, and you can look at each one and answer for yourself. Is that yes or no for me? And if it's a no, it's a bit of a flag that you need to maybe have a discussion about that with your GP or specialist. So let's go through the 10 points of the new checklist. So the first point is, have you had spirometry to diagnose COPD? So as I said, COPD is an airway-centered problem, and that's why spirometry is how we diagnose it. So spirometry, you might have heard it as a breathing test or a lung function test, and it's absolutely what we call the gold standard way to diagnose COPD. So you can't have a diagnosis of COPD that's just made on a chest X-ray or on a CT scan. Sometimes we can see emphysema like that, but you cannot diagnose COPD unless you've had spirometry. So if you've never had spirometry but have been told you've got COPD, then I'd really encourage you to go back to your GP and ask to be referred to have spirometry. Now, spirometry can be done both in the community, so some general practices do offer that test. It can also be done in many hospitals. So most teaching hospitals and local hospitals will offer lung function testing, and it can also be done if you're seeing a private respiratory physician in private laboratories. So spirometry is quite accessible, less accessible if you're in rural areas, but it is a widely available test. As I said, if you haven't had it, you really should think about it. If you're over 35 and you've got risk factors for COPD, it's great to have your lung function test. And the other question is whether people with COPD should have repeat lung function. That's a difficult question to answer because there isn't a lot of evidence saying that we should do it, but we do know it is useful. So it can be helpful to see if someone's lung function is getting worse. It can help us in decision making and also perhaps thinking about, whether we want to change inhaler therapy. So it's not absolutely mandated that you have to have it every year, but for many of us, we would like to do the test regularly with our patients so that we can see what's happening. So the second point on the checklist is to make sure you have an action plan. And your action plan is typically filled in by your GP or perhaps a nurse in your GP surgery, or it will be filled in with your specialist. And there are many different versions of action plans. This is the one that the Lung Foundation has available on their website. But some hospitals have their own. So my hospital has its own COPD checklist, action plan. So ours looks quite different to this. So if yours doesn't look like this, it doesn't matter, as long as you have some sort of action plan that tells you what medications you're taking normally. So typically your action plan will describe your inhalers and how frequently you're meant to use them, just as a kind of a bit of a memory prompt. And then on the next part of the action plan, typically you find information about symptoms that should alarm you. So if your symptoms change, particularly if your symptoms have changed over a few days and you've got more cough, more sputum, more breathlessness, or symptoms of infection like having a fever, those symptoms will be listed on your action plan to warn you those are not normal. So everybody has day-to-day variation in their symptoms, that's okay, but it's when there's been that step up in change in symptoms and we're worried then that you're having an exacerbation or flare. So your action plan usually has that information on it, but then it also has what you should do if you have an exacerbation or flare of your symptoms. And that's why it's usually filled in with your doctor, nurse specialist or specialist, because what we do is write down what you would need to do if you're unwell. So typically I will write down for my patients that they might take some prednisolone for a certain number of days. I write the dose, and I also write down the antibiotic that I want them to take at the same time. And then, so you usually get your action plan together with some prescriptions, because the idea of an action plan is to help you to recognize if your symptoms are much worse and enable people to start treatment quite promptly so that they're not waiting days to get an appointment with a GP, but actually able to proactively manage those infections at home. So again, if you don't have an action plan, it's really important you have a chat to your GP or your specialist to say, is this suitable for me? can I have one of these? And I should stress it's not suitable for everybody. So I've got some people who can't manage an action plan, particularly some of my patients who've got multiple different problems or who maybe got some mild dementia. So some people can't manage these, but for the majority of people, we do recommend having an action plan. So please do bring it up with your GP if you don't have one. The third thing on the Lung Foundation checklist is to make sure you know what medications you're taking and how often you should be taking them. And I'm talking about your respiratory medications here, because many people who come to see me will have a list as long as their arm for all the things they're taking. So I'm just focused on your respiratory medications at the moment. And so this is often written on your action plan, as I was saying before, but if you don't have an action plan, maybe you've got your medications written down. But it's really important that you actually know what they are and how frequently you're meant to be taking them, because it's not uncommon that someone comes in to see me and I realize that they don't know how to take the medications correctly. So particularly 20 years ago when we didn't have many inhalers, I often saw, we would have people who took 2 inhalers twice a day or 1 inhaler once a day and the other one twice a day. And when people are used to just always doing that, when they get a new inhaler, they don't realize actually the dosing frequency is different. So it's really important you know what you're taking, how frequently you're meant to be taking it, but also know about the side effects, because different inhalers do have different side effects. And so it's important to know what you can do to prevent those side effects. The next thing on the checklist is to consider, not only do you know what you're taking, but do you actually know how to take them properly? And again, these days, we are very lucky in Australia that we are able to prescribe numerous different medications for COPD. And I say that because I know our colleagues in New Zealand do not have access to the same number of treatments we do, but we're really lucky that we've got loads of inhalers that people can utilize. And that's great because it means like an individualized treatment for each person. But that also means there's more risk that people don't use their device correctly, because there are many different inhaler devices now on the market. And so you might have been used to using one and maybe your GP or your specialist suggests you change and you don't know that actually you need to use it in a different way. So for example, some inhalers you need a spacer, but for others you don't. So it is really important whenever you're given a new inhaler, or just regularly, at least once a year, that somebody checks your inhaler technique. Because the biggest reason, or the most common reasons that inhalers don't work, is either the person's not using them or actually then inadvertently not taking them properly. So make sure that you get your GP or the nurse in the practice or your specialist to check your inhaler technique. Your pharmacist can also do that as well, and your pharmacist can show you whether you need a spacer or, sometimes when you've got to refill the device, your pharmacist is also a great person, great resource to talk to about different medications. And some pharmacists will do home medication reviews as well and can look at all the medications you're taking and help explain them. So they're a really useful place to go for a little bit more support. The next thing on the checklist then is to think about whether you're up to date with your vaccinations or immunizations. And this is absolutely critical because from my perspective, I want to keep all my patients as well as possible. And that means preventing infection, because every infection that someone has can cause a flare of their COPD, which can lead to worsening damage and worsening symptoms. And sometimes people come back and are completely normal after an infection, but sometimes we see a step down after an episode of infection. So every infection we can prevent is absolutely critical. And that's why your GP and your specialist probably bang on about having immunizations, because to us, this is really, really important. So generally, we'll say to everybody that they should have a flu vaccine and that people should keep their COVID vaccines up to date. But the other one that's important is the pneumococcal vaccine, which is on the National Immunisation Programme, which means it's funded by the government after the age of 70. And there are 2 vaccines that are 5 years apart, and then you've completed the pneumococcal course. And pneumococcal pneumonia is the biggest killer of children under 5, and it's one of the most common unfortunate killers for people who are a wee bit older as well in terms of causing pneumonia. And the other vaccine that we do recommend these days, but which unfortunately is not yet on the National Immunisation Programme, meaning it's not yet subsidised, is the RSV vaccine, which is for the respiratory syncytial virus. So respiratory syncytial virus can cause problems in very little children, but it also can cause severe respiratory illness in older adults in particular. And so it's a real issue. So I've had many COPD patients become profoundly unwell with RSV. And this year in Australia, we've had 2 new RSV vaccines come to the market. So they are available, but unfortunately, people do have to pay for them. And hopefully that changes. But most national guidelines and international guidelines now recommend that we do tell people to have that RSV vaccine as well, as long as for them it's an affordable thing. So it's important to think about all your vaccines. And again, this is just something to check in with your GP or your pharmacist, because often they can check your record to see which you've had and which you're due. The next thing on the checklist is whether you've ever done pulmonary rehab. Now, pulmonary rehab is really a very sophisticated program that involves both education and exercise. So pulmonary rehab has been around forever and a day. We've been recommending this for a very, very long period of time, sort of about 40, 50 years actually. But we know that still only 5% of all the people who are eligible and who would benefit from an action plan, pulmonary rehab with COPD ever actually complete the program. So we really don't get people through, and that's for a variety of quite complex reasons. But so pulmonary rehab is typically a program of 6 to 8 weeks, and usually you can go to a centre or do tele-rehab, and I'll come back to tele-rehab in a second. But typically you would go to a centre and you'd go twice a week. It's usually in the community, and it's typically led by a nurse or a physiotherapist with expertise in pulmonary rehab. And what happens is you do some assessments to work out what you can and can't do, and you get given a personalised exercise program. And typically you would exercise for an hour, but it's really, it's not intimidating exercise. It's exercise that's designed for you as an individual to help you to improve your exercise capacity without pushing you too far. So you usually exercise for an hour, but then there's an hour where people get to socialize and there's education. So typically people learn a bit more about their COPD, their diet, and other aspects of better caring for yourself. So it's a really important program, and we know that actually it can really help with many of the symptoms. In fact, it's one of the most evidence-based interventions that we have for people with COPD. With COPD, the pulmonary rehab programs that we recommend, typically we always say to do a centre-based program, but actually for about 20 years we've also known that it's just as good to do pulmonary rehab through tele-rehabilitation, which is where typically it's done online, and it's done as the same sort of structured program. So depending on where you live, you might find that the nurse or the physio comes to your house with some equipment, they do the assessments, they give you that individualised program. And then actually when you're meant to be doing the program twice a week, they often are online with you and are watching you and encouraging you and motivating you. So tele-rehab is great, and it's a really good alternative, particularly for people who can't get to a rehab centre, perhaps because they're working or there isn't one near them, or they've got other commitments, or maybe they're so breathless they don't want to go in person. So it's a really good alternative. And a lot of the clinical trials show that it's just as good as going into the centre. So it's important that we have different options for people. And one thing I should stress is that rehabilitation, we know it's actually really important after someone has had an exacerbation. So there used to be many, many years ago a fear about telling people to exercise after they've had a flare or been in hospital. But actually we do know that it's really important, and it's a key opportunity to recognise who might benefit and to get the referral and to encourage people to go to pulmonary rehab. And the other thing I actually just want to say about pulmonary rehab is you can do repeat programs. It does depend on availability where you are, but I have many patients who'll come back and say to me, I'd like to do it again, and then I just re-refer them. Sometimes there's a longer waiting list to do it again, but we can still see benefits when people do a repeat program after a year or even a few years down the track. So the next thing on the checklist is trying to stay active. So as I was just going on, pulmonary rehab is a great way to learn what you can do safely in terms of exercise. And pulmonary rehab has fantastic benefits, but the biggest reason that people lose those benefits is they stop being active. So if you do pulmonary rehab and then you completely stop doing any exercise, the benefits are lost actually really quickly. So it's important for all of us to be physically active every day. And so that's why everybody is recommended and told, do 30 minutes of exercise or physical activity every day. And I guess the thing that's really important to understand when you've got COPD, that doesn't mean you need to do 30 minutes in one go. It could be 5 minutes walking and then a rest, and maybe you come back an hour later and do another 5 minutes. But it can be built up so that you get that 30 minutes cumulatively over the day. And typically what I say to people who come and see me is either to do some walking, if you've got stairs, to go up and down the stairs if you can manage those. But the other thing I often tell people to use is an exercise bike. So again, that can work well, but that's something to chat with your own GP and specialist. But trying to find something that you like doing and enjoy doing to help you to stay active is really important. The other thing that many people like doing is walking the dog. So Ken was telling us about walking his dog. I love my dog too. My dog's called Bertie, and Bertie's been unwell, so he couldn't walk with me this morning. But dog walking or gardening. So again, it doesn't have to be something, you know, oh my gosh, I've got to exercise, this is really dull. Make it something that you like and actually want to do, because that's really critical. The next thing to think about on the checklist is, are you smoking or vaping? And I ran the oxygen service at the hospital where I used to work, actually. I ran that for many years, and I always used to hold oxygen up as a carrot. And what's really important to know is most people don't need oxygen, and oxygen is really difficult to use for some people, and it doesn't actually help with some symptoms. But I would often say to people, gosh, you know, if you stop smoking, then I can consider you for oxygen therapy. And then people would stop smoking, and lo and behold, their oxygen saturations would improve, and so would their symptoms. So we know that stopping smoking is one of the most important things you can do, not only for preventing your COPD getting worse, but it's actually one of the most effective ways to improve symptoms. So particularly cough and breathlessness often improve markedly when someone stops smoking. But saying that, it's really easy for me to say, oh, you have to stop smoking. It's really easy to say that. It is not as easy to do in reality, and we all know that. So in fact, we know that on average, it takes people about 7 goes to quit. So if you're in that space, you are not alone. And it's really important to talk to your GP about things that can help you quit. So there are some medications, and you have to be assessed for them by your GP to see if they would be useful for you. In this country, we do not recommend vaping as a smoking cessation practice. So we know that vaping can have some immediate harms, but there's also growing evidence that vaping actually causes long-term harms as well. One of the biggest things with vaping is who knows what's actually in the vaping liquid that you're taking, because there's all kinds of impurities and nasty toxic chemicals. And when you're taking liquids like that are superheated with metals and all types of hideous chemicals in them, the chances are they're going to be doing serious damage to your lungs. So we actually actively discuss vaping and try and get everybody not to vape. So don't even start, but don't use it as a smoking cessation strategy either. If you want to stop smoking, you're currently smoking, have a chat to your GP or chat to the Quit line, because it's really important to think about this, and there are many resources to help. So 2 more things to talk about on the checklist. The next one I want to bring up is mental health or psychological symptoms, because mental health can be words that people don't necessarily want to hear. So I particularly look after people with severe lung disease, and about half to 2/3 of people who come and see me will have psychological disease. In fact, most people who come and see me have on average about 8 different medical problems, and psychological problems are often among them. And the reason we ask about them is because we know they have a huge impact on the symptoms. So I've got many people who are really breathless, but they're also really frightened. And to some extent, that doesn't surprise me that someone's frightened. I'm more surprised when people tell me they're not, actually. But it's just that you don't have to live like that. You don't have to live with those symptoms. So people will often say they're frightened, they have panic attacks, people can feel really sad, they can feel frustrated. They can feel really cross and grumpy because they just don't like having to live with their symptoms. So it's really important that we ask about it. So if your doctor or your nurse asks you about this, they're not belittling your symptoms and implying that you're mad. Actually, what we really want to know is, how can we help you in a really holistic manner? Because those psychological symptoms are often really, really debilitating, and yet there are things we can do about them. There are psychological non-drug approaches that can be really, really helpful for people who are experiencing anxiety or depression, and there are medications. So it's really worth actually bringing them up. If no one's ever asked you, mention it to your specialist or your GP or a nurse at the local practice and ask for help, because there are lots of things that can be done. And of course, there are lots of support lines out there as well that can be useful if you're experiencing those symptoms. And the last thing I just want to mention is, it is so important to have a regular checkup when you have COPD. So that checkup can be from your GP, or it could be, if you've got a respiratory physician, that you're seeing your physician every 12 months just to check in on how things are going. And obviously the whole of this checklist can be the thing that you go through with your GP or your specialist. But as I've mentioned a couple of times, there are lots of people who are really important in the care of someone with COPD, and that might be a respiratory nurse from the hospital, or the nurse at your local GP surgery. It might be your pharmacist. You might have a social worker or a psychologist or a dietitian. So there are lots of people who are often involved in the care of someone with COPD. So use all those supports and use them to help you to live as well as you can with this condition. But always remember to try and make sure you see your GP or specialist every 12 months to get that check-in and to make sure that you're actually going in the right direction. Because if you're not, we need to do something about it. And on that note, I will stop talking, but I'm happy to take some questions later.
Thank you so much for that, Natasha. That was really helpful. I think going into depths with each of those items on the checklist, not just as items, but why we're actually doing them, why they're important. So I think that was really comprehensive and helpful overview. And also that there are many things that people can do to manage their COPD. So I think the words that you used were optimize your care. I like that. It makes a lot of sense. So, having said that, if there are any questions that come to mind, please, again, invitation is there to submit them into the Q&A box in the toolbar. And we'll go from there. We'll answer them as time goes on, but we do have some pre-submitted questions. And these are for our consumer panelists, so for Naomi and Ken. So the first pre-submitted question we have for today is, reflecting on your own COPD management, can you tell us which actions from the My COPD checklist you found most helpful and how have these impacted your daily life? I'll hand over to you to start with, Naomi, and then followed by Ken, if that's okay.
So reflecting on my own COPD management, my COPD was confirmed by spirometry. A lot of people are actually misdiagnosed or they don't know the grade of their condition, which is why I think that spirometry is one of the most important things. With spirometry, we get a grade of 1 to 4, and it helps us understand how severe our COPD is and make sure that we get the right treatment. I myself was misdiagnosed. I was diagnosed in my 30s with asthma. After I requested to get my asthma tested, I realized that I didn't have asthma at all. I had COPD. So for me, spirometry is just so important. Because of that, I was put on the correct medication, a dual medication that has helped me breathe so much better, and it improved my lung function like exponentially. So yeah, I think that spirometry for me was the most important.
Yeah, thank you for sharing that, Naomi. It's a really good point because it is unfortunately quite common that we do hear that people are incorrectly diagnosed, or they may even be diagnosed with COPD when they've not had the spirometry test, similar to what Natasha was saying before. So I think that's a really good point. So thank you so much for sharing that as your insight. And Ken, I'll hand over to you.
My major thing was I've always worked in the building industry, and I smoked, and I smoked a fair bit because that's what all the men did in my day. And I was first diagnosed, as I said earlier, I think after I had pneumonia. I was diagnosed with COPD, and I quit smoking, and that is probably the hardest thing I've ever had to do. And I can't stress enough how helpful the Quitline people from the Cancer Council of Victoria were. They talked me through, they helped me immensely, because I wouldn't be alive now, I'm quite certain, if I hadn't done what I did and then got referred to a specialist who did the spirometry and confirmed that I had COPD and I needed to start taking daily action to do something about it. But first of all, nothing could have happened until I quit smoking. And that's the most important thing, and it's on the list there. Then, of course, spirometry was part of the way of diagnosing what was really going on with me and what I needed to do. So, I had to stop smoking first. That's my most important thing. It was 24 years ago on the 17th of August in 2002. And I remember that date because it was just that I happened to be able to stay alive because I was in hospital and they helped me get through, and I won't forget that day. That's when I started on my journey that I'm still on in dealing with an illness that I have and I have to deal with daily. I can't not deal with it daily.
Yeah, that's a really good point as well. Thank you for sharing that, Ken, because quitting smoking is one of the hardest things that things that people can do. And yeah, congratulations, you're able to do it many years ago. And there are certainly more treatments and supports around it these days as well. All right. So the next question I have for Naomi and Ken. So what challenges, if any, have you encountered while trying to implement some of the steps from the checklist? And how have you overcome these? So Ken, I'll hand it back over to you to start us off, and then Naomi will also share. So
Okay. Look, this one is it's a personal story, and it's not quite on topic, but I think it is. Last year I was in outback Queensland, a long way from anywhere. I went, I was probably 200 kilometres west of Cairns, in the middle of nowhere, and I had an exacerbation of my emphysema, and I was in a really bad way. I was very, very unwell, and I was in a little town that I think had something like 120 people total population. Fortunately for me, the town had a lovely nurse, an older lady who knew what she was doing. I staggered in the back of a van from the local pub, come shop, come everything. And she took one look at me and said, "You're a crook, mate, get in that chair." And she put me in the chair and put a nebulizer on, and I sat there for quite some time, and after a while she said, "Oh, thank goodness for that." And I said, "What do you mean?" She said, "Oh, it's starting to break up." and I said, "What do you mean?" She wouldn't say, but I realised later that if her action hadn't have taken place, the only option for me was flying doctor, and that would have been quite a few hours away. And if I didn't get well enough by the next morning to catch the train I was travelling on, I would be stuck there for a week. My mistake was that I didn't do what I've done before in my travels around the place. I didn't have my emergency script or tablets with me. I'd completely forgotten. My consultant had retired, he was a lovely professor. He'd retired, and I forgot that I have to take stuff with me. I can't go anywhere, even slightly remote, without either the medication itself or a script with me. This time when I came back, I went and saw my GP and then saw the specialist. I now have a script on my phone, which goes with me everywhere I go, and I can, wherever I am, if I'm starting to really get an exacerbation, I can go to the nearest chemist and get whatever it is that I need. Also, just a word of warning, because when I got back to Melbourne, I went to my GP. My normal GP was unavailable, so I saw someone else. Excuse me. And he said, "Go home, you need a lot of rest, go home, take a couple of Panadols." I thought, that's not going to work. So I made an appointment to see my GP. He immediately put me on steroids, and I was tripping around the room, but it took me quite a long time to come good. What I'm saying there is not every GP knows what to do. In the same practice, one GP knew what to do, the other one didn't have a bloody clue. And it's really scary, but if we're aware of it, we know what the plan is, and this is why I love this plan that we're looking at now, is that I sometimes know more than they do on what they ought to be doing. So, it nearly took my life to realise I've got to be proactive, not reactive.
yes, such a good point. Yes. And sometimes that can be the hardest part, is actually getting that COPD action plan and just making sure that, you understand it and your doctor's on the same page. So I think that's a really good lesson that you've shared there, Ken. And yes, being prepared also for flare-ups, expecting the best but preparing for the worst as need be. Yeah. Thank you. I'll pass over to you, Naomi.
One of my biggest challenges, following on from what Ken said, is I am a working mother. I have a new mortgage. I have to work, and my age bracket, I'll be working until I'm 70. So I'm going to be working for quite a long time, so my biggest challenge has been accessing pulmonary rehabilitation. We don't have any pulmonary rehab available in my area, or for what I'm led to believe, I've never heard of it in Adelaide at all. The classes are all designed for people who don't work. They're at the local hospital. There's no way that I would ever be able to access that without taking significant time off work, which is not viable. The way I've overcome it is just by using my chronic disease management plan, and they've referred me to an exercise physiologist at a gym. Now, I haven't accessed it yet, but I have been told that once I do access it, they should be able to give me some hints and tips and exercises that will be designed specifically for me. Obviously, it won't be as good as pulmonary rehabilitation, but it's something. The other thing I've done to overcome it is I decided to become a Lung Foundation advocate so I can champion my own cause so that we can have inclusivity of services for everyone, no matter who you are, how old you are, where you live, whether you work or not. So, yeah, that's what I've done.
Yeah. Okay.
Well, yeah, that's amazing, and yeah, we're very fortunate at Lung Foundation to have you as an advocate as well, Naomi. So thank you for the work that you do. And yes, good point with the pulmonary rehab access, and the issues around accessing it, because it's a fantastic program, but as you say, it's not necessarily easy for every single person to access. So yeah, it's a good point. And the next question before we move on to the Q&A, so for someone newly diagnosed with COPD, what advice would you give on how to get started in learning how to manage their condition? So Naomi, I'll hand back to you if you pop yourself off mute, and then we'll go over to Ken.
Okay, so for me, my advice would be, number one, do the COPD checklist. That's going to guide you through all the steps and things that you need to know along your journey. The other thing would be to complete the COPD action plan with your GP. However, like Ken said, you can come up against some resistance. I've had the same thing. I've gone to a GP and I've tried to get an action plan. Oh, you don't need that. Or no, you don't need a script right now. So in a lot of cases, you may have to advocate for yourself. And so you'd have a choice, change your GP a specialist, or just insist that, no, this is going to help you manage your own well-being. So insist that you complete it. Talk to the Lung Foundation nurses. When I first got diagnosed, I was scared because I was in my early 40s. I had a young child. I knew how long I had to work. The only thing that I really knew about COPD was late stages. So it was quite frightening, but the Lung Foundation nurses are amazing, and I can't stress enough how much they helped me put everything into perspective. And also too, in saying that, with the Lung Foundation nurses, also access peer support. The Lung Foundation has some amazing services. They have Peer Connect, which you can talk to someone directly with your condition, or there are peer support groups all around the country. And lastly, knowledge is power. Use all the resources that the Lung Foundation has to arm yourself with the knowledge to help yourself. I know that in normal circumstances, you might think, oh, well, I can rely on my GP or I can rely on my specialist. But unfortunately, with things like COPD, especially the stigma that you might face, you're going to have to advocate for yourself. So the more knowledge you have, the more power you have to advocate for good choices for yourself, for your well-being, and it also quietens the anxiety you might feel after diagnosis. Once you have that knowledge, you're maybe no longer so frightened, because you know that however bad you thought it was, that's not actually how it's going to be.
Yes, yes. Self-advocacy. Yes, I'm really glad that you mentioned that. And often when I have my first appointments with people over the phone that might have been newly diagnosed with COPD, I also raise that fact of reaching out for support. So just enveloping yourself with as many supports as possible. So I'm really glad that you mentioned that too, because it makes a world of difference. Yes. And Ken.
Yeah, well, I can just say tick, 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 tick. Well done, Naomi. Everything you mentioned is very valuable. And if I had the support of the Lung Foundation in after my diagnosis, it would have made it so much easier for me. I worked as a builder, which I think I mentioned earlier, and I've always been pretty active, and I didn't like the idea I had to take things very slowly at first, because I did to take them very slowly until I started to get a bit more well, and gradually I was able to increase my workload because I started to understand how to deal with my illness. So I can't do 100% full on all the time like I used to. That's part of my personality, unfortunately. My daughter still tells me now that I could slow down and not do so much. That I'm involved in a lot of things, and that's where I learn these days. And I've done my rehab, pulmonary rehab. I've done a couple of courses, and I've done other things. But as we both mentioned before, one of my main things in keeping me well, and it would have helped when I first got diagnosed, is having a medium-sized dog that just wants to get out at 8 a.m. no matter what, gets me out of bed, and I've got to take him out to do his business, and then he needs to go and play ball and whatever. So, it's one of my main things that motivates me. On some days in Melbourne, we had a few days not long before I came away. It was really humid, and we had high pollen counts and all that, and it wasn't good for me. So I had to do a bit of shutdown, which is something that I don't like doing, and I had to stay home mostly or have the aircon going when I really didn't need it. So it's important for me, it's been so important to recognise that I have an illness that can really do me vast harm if I don't work with it, and the action plan and all the things that the Lung Foundation put out have been so much help. And being involved, as Naomi said, on the council, the committee of it, whatever, a CAC committee, and I'm involved in other areas of medicine in the hospital situation, and it keeps me at the forefront of knowing that I have to deal with this. It's not going to be fixed by itself. I have to keep cracking on. So it's important that we don't just say, well, I've had my medicine, that's all I need to do. I need to work on it. I can't just take my puffer in the morning at night and say, I'm right now. That's not going to work. It's the action plan and all the things that go with it. It's multifaceted.
Yes.
Yeah.
Yeah, it certainly is. It's a good point. It's a holistic approach.
Yes,
The best approach. Yes, yes. Oh, thank you so much for all of your insightful responses and for sharing so generously as well. So we will now move on. We've got about 10 minutes left. So we will now move on to our live Q&A session. So please continue to send your questions through while our panelists are with us. And once again, please note that the questions should be just of a general nature. Any really specific questions do need to be referred to your treating doctor. Okay, so we have our first question in, and I will probably direct this to Natasha. So the question is, should inhalers be taken using a spacer to ensure that the correct amount is received?
That's a very good question. The broad answer is yes, but it does depend on the type of inhaler. So the only ones that need to be used through a spacer are puffer type devices. There are many other inhalers, for example, dry powder inhalers, so the typical twist and turn and you pop it straight in your mouth. And there's also the soft mist inhalers, which do not need that. So dry powder and soft mist do not. There's also a new product on the market, or it's actually been around for a couple of years now, which is made by Chiesi, and their drugs are an ultrafine preparation, and they also say that you do not need to use a spacer with them. So while we've always said, yes, use a spacer, and that's generally the advice we would give, it's actually not true for certain devices, and the new Chiesi inhalers, they do not recommend using a spacer with it because you don't need to.
Yeah, thank you for clarifying that, because I think there is some confusion around which devices do we actually use for spaces, and it can get confusing. So thank you for that. The next question it's more a medication related one, so probably again for you, Natasha. It is around bringing up more phlegm. So does Breztri bring out more phlegm than Symbicort?
The short answer to that is no, and the other side to that is neither of them are actually designed to help you bring up your sputum. So inhalers, so Breztri is a triple inhaler that contains 2 long-acting medications to keep the airways open, as well as a steroid, and only some people with COPD need that steroid. And Symbicort is a steroid with 1 medication to open up your airways. And so what they're trying to do is prevent inflammation and open the airways as much as possible. They're not actually specifically designed to help with sputum clearance. So if people do find their inhalers help with sputum clearance, that's nice, but that's not actually what we're looking for when we use them. When someone has problems with a lot of sputum production, I will often ask them to see a respiratory physiotherapist to learn really simple techniques that they can do at home. So we very rarely recommend old-fashioned percussion and tipping. We actually get people to learn techniques that they can do themselves to bring their sputum up. So for example, typically someone sees a physio and they're taught to blow bubbles through a bottle of water, and that can help with sputum clearance. And there are many other things that we often utilize, but once we've got the person to see a physio. So inhalers are not generally one of the strategies I utilize. If someone tells me they find it helpful, that's great, but we're not looking for that effect, and so we don't expect that one is better than the other.
Yes, thank you for clarifying that. The next question is around exercise. So the question is, I exercise for 40 minutes a day, 6 days a week. Does this help my COPD? I might pass over to Naomi and Ken just to share their experience on how you found whether exercise does help and how it helps. So Naomi, I'll pass over to you.
Well, I actually walk a lot through my work. So I don't specifically exercise for a certain amount of time. We have a very large factory, and walking from one side to the other actually takes about 5 minutes. So I do the 10-minute walk a lot. I think it does help because I know so for example, on weekends, if I don't do as much, I definitely think that it makes breathing easier.
Yep, absolutely. Yeah, it helps to open up the airways. And yep, Ken?
Yeah, look, I get back, for me, I don't have any set regime of exercise, but as I said earlier, I think I'm always been an active person. I take my dog out to play with the BALL at least once a day, and I try and take him to the DP. He's next to me, so I've got to not say the words. And just in going to the DP, he plays and I walk around and talk to people. And I also am fairly active I live in an old person's village. I'll keep it nice. And I'm actively helping me and others do stuff, make things and whatever. And we've got a nice workshop which I can use. And so I'm very active doing things, physical things out and about. So I don't have an exercise regime as such. I would just find that too boring to do. I'm not very good at self-discipline like that, but I'm also couldn't stand just sitting around doing nothing. It just wouldn't work for me. But knowing that I need to get things done, I do, and it's my lifestyle. I live in a beautiful area where there's lots of trees at the end of my village. There's a leash-free dog park. My daughter lives 4.5 kilometres away, so I take my dog over to play with her dog, and so we get over there, and my job is to continually throw balls and retrieve them from under things and whatever. So I keep busy in my lifestyle. I think that's my answer to that question.
Yeah, yeah. Thank you for sharing. Yes, and it does form part of my COPD checklist exercise, so keeping yourself as active as possible. The next one I will direct back to Natasha. So this is a good question. My GP said I wasn't sick enough for pulmonary rehab. What should I do?
Yeah, awkward, isn't it? Everybody should do pulmonary rehab is the answer. And so if your GP has told you don't need to do it, then what you do is you politely go back and say, actually, I've just watched this webinar from the LFA and they said I should do pulmonary rehab. Would you please refer me? And I think Ken and Naomi both said this quite clearly when they were talking earlier, that sometimes if you find your GP or your specialist isn't working with you and isn't listening to you, then sometimes you have to think about somebody else and involving somebody else in your care. And so, sometimes if you go back and your GP doesn't want to do what you know will help, then you have to think about, is that the right person to care for me long term? And I say that with a heavy heart because it's really awful to interrupt long-term relationships, but equally you need someone who's going to actually be up to date and tell you what to do. And everybody with COPD generally needs to do pulmonary rehabilitation, and doing it, the biggest issue when we leave it till too late and someone's very severe is when they really struggle with the program.
Yes, yes. Thank you so much. Thank you all so much for sharing your insights, your wisdom, your experience. It's been very helpful for myself, but I'm sure everyone else that's been tuning in as well. So that's probably all we have time for in terms of Q&A, just being mindful of time. So if you have any questions following today's webinar, please feel free to reach out to us here at Lung Foundation Australia via the number on the screen. So that's 1-800-654-301. If you press option 3, that will take you through to our friendly information and support team who can direct your query. There's also an email address that you can reach us on as well. We do have, if you're not already aware, we've got the respiratory care nurse service. So I'm one of the respiratory care nurses on that service. So we offer you telephone health appointments over a few months just to make sure that you're receiving evidence-based care and help to empower you to access the right care and supports for you. We do also have COPD peer support groups. There's a few different options there. We've got online support groups, face-to-face support groups in some areas, not everywhere yet, unfortunately. And we do have Peer Connect, which is a one-on-one telephone-based support. And the other thing I wanted to mention as well is a more recent offering that we have here at Lung Foundation Australia. So it's the COPD Learn and Connect program, which is run by the respiratory care nurses. We run a session once a month at the moment on a different topic related to managing your COPD. And you need to attend live. So that's a live and it's an interactive session. So we can chat with one another and you can ask questions. And they're designed for people that are living with COPD and their caregivers. And it's just that opportunity to ask questions, connect with others. And if you'd like to register for that, or if you're interested in finding out more, just give us a call again on our free call 1-800 number. You can also, final thing, I've got so much to share with you. You can also visit the Lung Foundation Australia website. So there's some QR codes there on your screen now to find out about more information and resources on COPD, such as those ones that are on the screen. We've also got the interactive My COPD checklist that Natasha spoke spoke us through today, plus the hard copy of the checklist. And that brings us to the conclusion of today's webinar. So thank you so much, everybody, for joining us today. We really hope that you found this webinar helpful and interesting, and that it answered some of your key questions, and that you're feeling a bit more empowered in terms of managing your COPD care and management. So wishing you all a lovely rest of the afternoon. Take care and bye for now.